Good afternoon. Could we please start the event? Good afternoon, distinguished delegates, colleagues and friends. It's my pleasure to welcome you here today for this side event entitled Advancing Collaboration for the Continuum of Care in Drug Demand Reduction. Thank you all for coming here and for supporting this event. This is a big room, so it feels a little bit empty, although there is lots of people. We want to first thank our supporters and collaborators, especially co-organizers. First of all, Celebrate Recovery, also Drug Free America, WFAD, who really participated in this process, as well as UNODC and the Institute for Public Health of the Republic of Croatia and also Slovenia. So a couple of housekeeping information. We are holding this event in hybrid way, so we do have more than 20 people online already, and I can encourage everybody to ask questions. The questions will be answered either during the event or by email afterwards. I will not detain us very long, and our first speaker is the Professor Dr. Žarko Obradović, who has served as the ambassador to the permanent representative of the Republic of Serbia to the Organization for Security and Cooperation in Europe and other international organizations since 2022. He is also a professor at the University in Belgrade and former Minister of Education of the Republic of Serbia. Žarko, you have the floor.
Thank you. Thank you. Ladies and gentlemen, excellencies, distinguished representatives of international organizations, member states, civil society representatives, and esteemed friends. It's my pleasure on behalf of the permanent mission of the Republic of Serbia to the OSCE and other international organizations to welcome you to this roundtable organized by the government of the Republic of Serbia's Office for Combating Drugs. The event is organized in cooperation with Associate Professor in Criminology, College of Health of Humanities, University of the United Kingdom, Dr. David Patton, and the regional civil society organization Celebrate Recovery from Bosnia and Herzegovina, with support of international organization, United Nations Office on Drugs and Crime, the World Federation Against Drugs, the Drug Free America Foundation, the Croatian Institute of Public Health, and the Ministry of Health of the Republic of Slovenia. Fundamental issue in drug policy is reducing the demand for drugs. In times of increased psychoactive substance use, it's crucial to recognize that supply reduction and demand reduction are complementary areas that need to be mutually reinforced. A balanced approach is necessary both in the implementation of universal prevention measures and in providing professional support to individuals in the process of recovering from drug addiction, ultimately strengthening the social community. An important aspect of continuous protection and support for people who use psychoactive substances is the inclusion of young people and gender-sensitive groups, which contributes to the enhancing transparency, increasing inclusivity, and improving the effectiveness of such a protection system. Civil society organizations, based on the live experience of people who have used psychoactive substances, act as a bridge between social communities, health and social care systems, and public policy makers by advocating recovery capital, empowering peer education, and providing valuable insight grounded in the personal experience. The continuous work of competent state authorities in the Republic of Serbia in the field of drug policy is based on respect for the rule of law and social justice, protection of human and minority rights and freedoms, and assume the application of multidisciplinary, evidence-based, and effective approach to the treatment of addiction. As a government service responsible for coordinating work of state authorities in the field of drug control, the Office for Combating Drugs implements a comprehensive approach to drug control while respecting the basic principles and standards prescribed by the positive legal framework of the Republic of Serbia. Before concluding my remarks, I would like to emphasize that in accordance with the Stabilization and Association Agreement, the Republic of Serbia is implementing the necessary measures to ensure that its national legislation aligns with the acquis of the European Union. In order to nurture and apply European principles and values, the Republic of Serbia maintains a successful cooperation with the European Union Drugs Agency, which represents a key step in strengthening European Union capacities in addressing the health and security challenges posed by the market of illicit psychoactive substances. In addition to successful cooperation with the European Union Drug Agency, the Republic of Serbia also maintains strong collaboration with the United Nations Office on Drugs and Crime in the field of drug policy, continuously fulfilling its obligation under ratified United Nations conventions and protocols. The Republic of Serbia will continue its effort to enhance bilateral cooperation with all member states and strengthen civil society through implementation of effective and balanced policy in the field of drug abuse with the aim of improving overall societal well-being. Allow me once again to express my gratitude for your participation in this side event by the Republic of Serbia and for your willingness to contribute your expertise and experience to the quality of this event. Thank you.
Thank you so much. And first of all, I just want to thank you for always supporting us in these events and for highlighting how Republic of Serbia is really contributing and being a leader in the Balkans with all of these initiatives that really encompass all the pillars of drug policy. So thank you again for supporting us. Our next speaker is Danilo Balota. He doesn't need much representation from anybody, but he has been involved in the European international drug policy over 30 years, has joined the EMCDDA back in 1997 and has been working on national European drug legislation, policy, coordination systems, and contributing to the agency's work on international drug policy. Danilo, you have the floor.
Thank you very much for this embarrassing presentation after 30 years. It's time to go, as someone says. But I thank you very much for the invitation, the Office for Combating Drugs of the Government of Serbia. We are very close partner to you, and we are very happy that you have invited us. Mr. Ambassador, ladies and gentlemen, colleagues, friends. It's a pleasure for the UDA to be here, to be involved in this precise side event, because our key message is key, and effective drug responses exist. We are not in the situation of 30 years where the MCDA started. We know what works. We know also what doesn't work, not in all fields, but in many fields we do. And they require these measures to be implemented. And especially, as you suggested in the invitation you made me, in times of scarce resources. We cannot allow ourselves to spend the scarce resources in measures that do not bring any positive results for the citizens in terms of security, in terms of the health. So this is kind of a moral obligation that anyone in government capacity has and must respect. Our way to do that, and especially with the region of the Western Balkan partners, is through partnership. We really believe in the partnership through governments, professionals, services, and civil society. People with living experience, people will live the experience. I think this is a block, and we have to maintain this block together. We go through the IPA project, as you see in this slide. We are very recognizant to the European Commission to have funded this approach and to continue fund, because we need this financial support. We have the 6 beneficiary countries you see in this map, and the project, the aim we have is exactly that, is to diffuse, exchange best practice, to let the group knows what is working, what is not working, what gives results. And we are really committed at the UDA in implementing that very much. And we are committed in strengthening partnership, as this side event suggests, to strengthening collaboration between different layers of the government and different layers of the states, experts, professionals, and civil society. Next slide, please. We are in a nice situation actually at the moment, because we as UDA, we have received a new mandate, and with the new mandate, we have formalized the relationship with civil society. I was just discussing with our colleague of civil society here at the table that this month actually, we are opening up a platform on the UDA website where we will allow hundreds of civil society organizations to interact with UDA, exchange information, consult each other, pull out knowledge, and anything, it is possible at the moment. We are starting. And we have the wind of the European Commission civil society strategy adopted 2 months ago. So we hear very well the civil society's, let's say, field is shrinking. With UDA and at EU level, there is an opportunity. So we have to profit of this opportunity. And we have also a new international cooperation framework in which you see here the key partners, partner countries, of course, but also institutions and international organizations, international organization and civil society and academia. We want really to bring the society together because we are very aware of the dear situation in which we are. There are other regions of the world, we have to be, we have to recognize that probably are suffering more. This does not mean we have not to be pleasant. This does not mean that can be worse in the future. So we have to be prepared. We need to put in place tools that works in order to tackle drug trafficking, to tackle crime, tackle violence, but at the same time, put in place effective prevention, effective treatment, and good recovery for people who use drugs. I brought you 2 examples of the participations and the experience we are doing within the EPA. Next slide, please. For instance, we have done this. This is a new way of collecting data. Basically, we ask online, people use drugs. What is that you are using? So it's a really clear picture of what people are using in a territory. This is done for the partner countries in the Western Balkans. It's a very small sample. It's not indicative of the overall population, but among 4,500 people told us, of course, cannabis, but also you see benzodiazepines without prescription. This is something that we see, especially among young people, especially among students. So something we need to take care. Services need to know this data to consider how to deal with this. And cocaine, 21%. Of course, polysubstance abuse, this is not a news, is spreading. And the next one is a mapping we are doing of harm reduction and prevention services in the region. It will come up, this is a new thing that will come in the next months, the publication in the Western Balkans. What we discovered is prevention is mainly in educational settings. So there we can do more. There is more space. There is room for improvement. Treatment, without this would not surprise that OET treatment coverage is below WHO targets. There is limited treatment for other drugs, cocaine, for instance, or stimulants, but this is an European issue. We need to find better treatment outside opiates, and we are not prepared for that, maybe. And very few women limited recovery system. We know at the EU and with the UDA, we are very, very careful, and it's very dear to us, the gender issue. And we know that women, they need shelters, they need services that protect from violence. And a woman, drug addict, or with people who use drugs, that walk into a treatment center, and maybe there are only men in this treatment center, it's probably not the best way this could happen. And I'm a man, so I understand very well what could be. So there are ways, there are best practice. UNODC has done an incredible job here. I think is this what I was saying in the beginning? We know measures that exist and they are effective, and we should implement them. And we do regional capacity activity. Next one, for instance, spreading the early warning system. Early warning systems is the keywords. We need to be prepared. Fentanyl is arriving, it's not arriving. We need to have signals and sentinels to understand that. At the UDA, we are putting in place new tools to do that. We are very happy to share this knowledge, and also wastewater-based epidemiology, which is a very cheap and nice tool to understand what is consumed in certain territory. And next one, please, which I will stop my very short presentation. I want to thank the people in Lisbon that do this job, Rebecca, Ivy, Sylvia, Frederick, thank you very much if you are online, because they do a tremendous job to bring this IPA project forward. And for us, I mean, the key message is we have a lot to do. We have a lot to do, certainly, but we can find a way to do it, and we have to find a way to do it together in partnership. This is our message for today. Thank you very much.
Thank you so much, Danilo. And thank you again for all the information that you provided. It's really, again, devastating to see that there are no or very few services for women and adolescents as well. But hopefully with the new platform and everything that you're doing, we will have the opportunity to engage with other civil society organizations. Okay, our next speaker is Ms. Sunita Suhartono. Hopefully I have pronounced it well. I'm sorry if I didn't. She's Associate Drug Control and Crime Prevention Officer at the UNODC Prevention, Treatment and Rehabilitation Section. Since 2016, she has worked with the UNODC in various roles, including the headquarters in Vienna and the regional office for Eastern Africa, advancing the science-based approaches to treatment of drug use disorders along with continuum of care. So Sunita, thank you for joining us tonight.
Thank you so much also for inviting UNODC. And I'm actually quite happy that you placed me between EUDA and WHO. So as requested, I will be speaking about the interlinkage between drug demand and supply reduction, looking, of course, at the continuum of care. Slide, please. I would like to start by presenting some data from the World Drug Report. So we know that seizures in methamphetamine here has risen, but also, I mean, here you can see also the green bar or the green line in Europe. Seizures in Europe has increased, which also led to the consumption or increased consumption. In the past 10 years, you can see it has increased by 47%. So this slide should highlight that drug markets operate on demand and supply dynamics, right? Next slide, please. Here, I wanted to highlight that, especially in Europe, the World Drug Report stresses that clandestine drug laboratories were dismantled and that synthetic drug manufacturers are on the rise in Europe. Next slide, please. And this leads to the shift of global markets and increasing stimulant use. We heard from Danilo that the services for stimulant use disorders are not prepared, and I'm really happy, as said, that we have the strong collaboration also between the agencies. Just to mention the Scale Up initiative, which addresses the problem for stimulant use disorder treatment. But here I wanted to highlight that due to the cocaine trafficking or the rise in cocaine markets, so to say, also the cocaine consumption has been growing, particularly in Europe. Next slide, please. And here I just wanted to highlight in terms of drug demand that stimulants are the second commonly used drug type. As you can see, with amphetamine, cocaine, and ecstasy, almost 77 million people are using stimulants globally. Next slide. I just wanted to highlight also the shared vulnerabilities between people who are using drugs with drug use disorders, but also those who are engaged in crime, since I will be speaking about the interlinkages between drug supply and drug demand. Next slide, please. And of course, to provide effective action or solutions, we need to understand the vulnerabilities first in order to prepare tailored responses and then come up with effective actions, including policy making. Next slide. And here I just wanted to highlight where UNODC is working in terms of drug supply reduction. Of course, we work together with law enforcement agencies. We are active in addressing border control, of course, regulation of precursors, and also addressing organized crime and trafficking networks. Next slide. And in terms of drug demand reduction, as you can see, we have the two international standards, one on drug use prevention and the other one on treatment of drug use disorders that really cater for the continuum of care, which you can see the half wheel in the middle, from promotion, prevention, early intervention, psychosocial treatment, pharmacological treatment, recovery, low threshold services, and of course, long-term recovery, right? Next slide. And here I just wanted to highlight, since we're at the CND, that member states have committed to a continuum of care. It's in line with the International Drug Control Conventions, as you can see, addressing early identification, treatment, aftercare, rehabilitation, and social reintegration. Next slide. Of course, sustainable responses require integrated approaches. Here, I just wanted to highlight, since we are at the CND, that in terms of policy and operational services, when it comes to technical support, for instance, integration is key, providing treatment as an alternative, for instance, when we want to look at the interlinkages between drug supply and drug demand. And then when it comes also to addressing community-based services, not only working with civil society, but that their voices of the people with lived experience are also heard in terms of policy making as well, right? Next slide. Here, I just wanted to highlight that integrated health and social responses can contribute to all of these factors. So less drug use, less overdose, less involvement in drug use and trafficking, less violence, less illicit drug markets, less crime, less mental health disorders, and also less HIV and other infectious diseases. Next slide. Just to kind of end my presentation here, just wanted to highlight, since we are also marking 10 years of UNGAS, that the UNGAS outcome document have already mentioned the importance of cooperation and collaboration when addressing the world drug problem, right? Next slide. And therefore, integrated health and social responses are necessary to effectively address drug demand and drug supply. Thank you so much.
Thank you so much, Sanita, and thank you for reminding us it's 10 years from UNGAS, and I know that many of my colleagues have also participated in the process, and it's really great to see as well that some small steps have been made to improve the collaboration. Thank you also for mentioning the lived experience organizations, and with that I will kind of transfer to my next speaker, Professor David Patton. He's Associate Professor in Criminology at the University of Derby. And I can also add, he was my supervisor to my PhD, and I'm really looking forward to his presentation. His work focuses on recovery-oriented systems of care, also lived experience, leadership, inclusion of marginalized communities, and all of his kind of focus is on integration of community knowledge and institutional systems. He serves to His Majesty in prison and probation service in the UK, and also is the lead for recovery for Office for Combating Drugs of Republic of Serbia. I will stop there probably, but I just want to mention that he's also a founder of New Center Media. So thank you, David.
Thank you. And I'm breaking the convention by standing up, so I get nervous if I sit down. Thank you so much to the Serbian Office for Combating Drugs for giving me the opportunity to speak today, and thank you to everybody who's turned out and giving us your precious time and attention. We do appreciate it, and a huge thank you also to our sponsors for today's event. So really today what I want to do is to address a challenge that I think every nation in this room faces, which is the continuity of care breaks down precisely where people need it the most. At the point, oh, sorry, next slide. At the point of first engagement, when somebody's in that early stage of needing support, and also the transition points between services and institutions, having to navigate lots of different needs and provision, but then also during points of maintenance and stabilization along the recovery journey. But those gaps in continuity of care, unfortunately, are worse if you're a woman, if you're from a minoritized ethnic community, or if you're part of the LGBTQ+ community. And this all happens despite many countries' significant financial investment into such systems and services. And it also occurs despite the fact that lots of these institutions and services are built upon hard evidence and the latest scientific data. So then the question becomes, well, why is this occurring? If in some countries where there is that investment, both knowledge and finances, why does the continuity of care still a problem? And I think that it's complex and it's nuanced and it's dynamic, but I think one of the big reasons why this is occurring is oftentimes our systems run like parallel tracks. So each track, it's not just about the physical fact that, we have different organizations in different geographic locations, but it's much more deeper than that. The fact that each of these services have their own logics and worldview, their own models and language, that means that they never kind of come together. They operate beside one another and not with each other, or in acknowledgement of their own blind spots or their own deficits. Next slide, please. In my own work, I describe this using a symbolic framework of the two minds, left and right brain thinking. One mind, the left brain thinking, representing sectors such as health, criminal justice, and statutory treatment, is analytical, data-driven. It prioritizes structure and protocols, risk management, compliance, control, objectivity, supposed neutrality, and standardization. On the other hand, with the other mind, the right brain thinking represents recovery culture and Leros, where the knowledge base is relational and contextual. It prioritizes belonging, identity transformation, strengths-based practice, and community knowledge and connection. Now, both minds are essential, but because they operate as parallel tracks, it is the people who are seeking support and recovery who unfortunately suffer the consequences of this. Next slide, please. Now, the solution is not to choose one track over the other. It's not to try and permanently fuse them together. I believe they will always remain distinct. So therefore, the task before us is different. And I want to propose here today that we need to build junctions. Junctions are the places where people, knowledge and practice ripple and create something that doesn't exist currently. I call these neuroplastic system junctions. Places where something different happens, spaces where new pathways can form, and recovery capital generation can accelerate and overflow. So I'd like you to think of it like a tube map. Nobody would think about redesigning the tube system itself. Instead, what they do is they build new tube stations so that they can connect existing lines. And all of a sudden, suddenly, new journeys are possible. New pathways and new routes are created for people who travel along those tracks. And here's the good news. There are many junctions globally that are already in existence. The fact is, at the moment, we don't acknowledge them and we don't validate them. Leros are one huge example, and I'll talk a little bit more about that in detail in a moment. Inclusive Recovery Cities by Professor David Best is another fantastic example of how at a city level, new pathways are created and different services and community-led organizations come together to create junction points. But also initiatives like New Central Media, which I'm the founder, a publishing house that I created back in 2023 when I attended the CND for the first time. And in the last 12 months, we've created 3 edited books and 41 lived experience, paid and published authors. And as a result of those books, one on women and how women recover differently to men, one on the prison system and does the prison help or hinder recovery, and finally, on the role of Leros. What those books have done in a very short period of time is that they've validated lived experience as an alternative epistemology. as a valid form alongside academic forms, so-called scientific, hard evidence-based forms of knowledge. But right now in the UK, His Majesty's Prison System is currently having a book club, and the 3 books have been selected. And so all new probation staff are being trained on the importance of lived experience through the lens of these 3 books. And the prison services are just seeking funding to translate the prison book into an audiobook. And so the authors of those chapters, people who were in addiction, who are now authors, are going to be recorded. Their chapters are going to be played throughout every prison in England and Wales over the next 12 months. Thank you. Next slide, please. I've got 1 more minute, so I'm going to have to wrestle through the last 2 slides. In the UK context, LEROs have emerged as a vital part of a recovery-oriented system of care, and they exist in half of local authorities in England and Wales. And since the publication of the book in September 2025, a striking finding emerged from that book. What they showed was that actually LEROs create neuroplastic system junction points because of the mechanisms of continuity that they offer, some of whom you can read on the slide around out-of-hours support, so on and so forth. Next slide, please. But here's the challenge. Neuroplastic systems don't just happen by accident. And so continuity of care needs continuity of thinking and continuity of connection. When the systems and the thinking behind them is rigid, people break. Therefore, the junctions must be cultivated. So I'm proposing that we do something together, and that's really the theme that every speaker has raised about working together. So I'd like to propose this opportunity for a global neuroplastic system junction points learning partnership. There'll be 5 different elements, as you can see on the slide. And for me, I'm privileged to travel globally to observe recovery communities and practices all over the world, and also to research and publish in academic journals. And here's what I see from every nation that's represented in this room. You have too many parallel tracks and not enough junctions. And what we need to understand is that connection is not only essential for those people who are in recovery, but it's also essential for the systems that serve them. So if we want to build these junctions, we need to provide opportunities for the systems to finally meet. And when we do provide those opportunities, something new emerges that's much more than the sum of its total parts. A new type of architecture or space is created where new possibilities interrupt the old order. And in those spaces, a profound generativity is born, where new connections can form, new solutions emerge, but also importantly, people's lives can be renewed. This is what intentional design makes possible. So let's not just join tracks. Let's create the places where new worlds can be made together. Thank you.
Thank you so much, David. And I cannot even repeat what you said here, because a new kind of way of explaining what we really need. And I think this is a call for all of us to have you as a speaker on a very longer event, just to explain, because I think this is really a new philosophical and a very practical and evidence-based or experience-based way to create new evidence. So thank you for that. Our next speaker is Dot Smith. She's CEO of Recovery Connections in the UK and largest lived experience recovery organization. She's also a founding member of Kleros, and also she's strengthening peer-led recovery nationwide. With her 40 years in the sector, which I cannot believe, along with the lived experience, she drives community-centered lived experience approaches that build safe, connected, and inclusive networks. So, Dot, you have the floor.
Thank you, Molka. And just to extend a thank you to the Serbian Office for Combating Drugs for this real privilege to present the lived experience evolutionary story of recovery connections. Next slide, please. And hopefully we'll put into context some of what David was talking about. We have been in existence for 18 years now, and we've grown probably over the last 10 years to more than 150 staff with over 90% of our staff having their own lived experience, many of them having been supported by Recovery Connections through their journey. We support over 2,000 people every year, including residential rehab. We have a female residential rehab and a male campus residential rehab, as well as some intensive daycare programs. But largely, we offer community-based recovery support. We were the first UK inclusive recovery city. I'll talk a little bit more about that shortly. And I think that created a ripple effect of LEROs, lived experience recovery organisations like us, seeing that they had a really important part to play within the places that they lived and the places where, you know, many of their friends and families were stuck in active addiction. We also established the first collegiate recovery programme in the University of Teesside. We also now in Sunderland University supporting students in recovery to successfully navigate the world of higher education, and developed alongside Dr. Ed Day and colleagues the Collegiate Recovery Toolkit for the UK. Next slide. Ultimately, we are led by the people that we support. We work in 7 towns and cities in the northeast of England. Our staff are residents of those towns and cities, and we co-produce, co-design and co-deliver everything with the local community in the places that we work. They lead any developments that we do. They're an absolute, you know, resource of information in terms of prevention and drug trends in their local communities. Next slide, please. And this is what our model looks like. This is Middlesbrough. It's a town in the northeast of England that was largely industrial in terms of their main source of employment. That over the last 20 to 30 years, a lot of that industry's disappeared. So sadly, we rank very highly in terms of an area of deprivation, poor health outcomes, early death, drug-related death, and unemployment. But as a LERO, we have built a very visible recovery movement in Middlesbrough. We work alongside the treatment service providers to help people maintain, retain, and start their recovery journeys alongside substitute prescribing. We work with local employers through our IPS programme, which is individual placement support, to help people gain employment at the time when they want to get back into employment, something that is really, really important in terms of a recovery journey. We host many, many events and activities in the local community and for the local community, because people need to see recovery in action. People need to see that people can and do recover every day. For far too long, addiction and recovery has been stigmatised. So we really celebrate our events in local communities. Education, that I've already mentioned, is so important for people's recovery journeys. We facilitate people back into education and support them through that journey so that they can successfully move on to the place that they choose to go to in their life, with the education behind them to open the doors. And we provide a lot of training now. We provide training to anybody and everybody in local communities to understand addiction, to become more compassionate and to challenge that stigma. And we also train employers to better support their employees and prevent people from losing their job through randomised drug and alcohol testing or post-course testing. We want to get to people quicker. And an example of that is PD Ports. They are Teesside's biggest employer. They manage the port of the River Tees, and we've worked with them for the last 5 years to support their staff and reduce the number of employees that lose their job through positive drug and alcohol testing. Next slide, please. And this is a quote from Franz Kalle, who is the CEO of PD Ports. I think that there's just such a stigma around this issue, but on the same token, people probably don't realise the endemic nature of substance use in society in general, and businesses such as ours will reflect that very same society. Point being, you can't ignore it as it's more prevalent than people would like to admit, and that then leads to how you deal with it. You either help those people who reach out for help, and why would you not? And I honestly can only see upsides and benefits to this approach. So as a LERO, we are embedded within PD Ports. We have a recovery coach who works within that organisation to help increase compassion, reduce stigma and support staff. 1 minute. And my final slide is the College of Lived Experience Recovery Organisations has evolved over the last 5 years to support more organisations like us, because there are many lived experience recovery organisations that haven't been acknowledged within the treatment and recovery system, and CLERO exists to support those organisations and help them grow, develop and find their place. Thank you.
Thank you so much, Dot, and thank you for everything that you're doing. You have changed the way we see recovery and also in the UK and definitely in Middlesbrough and that kind of deprived areas of East or Northeast UK. So this is amazing and we are so proud of your work. Thank you. Our next speaker is Ms. Nina Grba, and she is the advisor at the Office of Combating Drugs of the Government of the Republic of Serbia, where she works on the coordination and development of drug policy and international cooperation. With the background in law, she graduated from the Faculty of Law of the University of Belgrade and has passed the bar examination, and she contributes to legislation, drafting, policy analysis and interinstitutional cooperation in the field of drug policy. She also participates in preparing all the national reports and strategic documents aligned with the UN and EU standards and represents the office in collaboration with international partners. Nina, you have the floor.
Thank you so much. Excellencies, distinguished delegates, ladies and gentlemen, on behalf of the Office for Combating Drugs of the Government of the Republic of Serbia and its director, Mr. Pekic, I would like to thank you for your presence. Today, I will present national perspectives on advancing the continuum of care in drug demand reduction. Next slide, please. So the office was established in 2014 as the National Coordination Authority in the field of drug policy. We ensure alignment between national priorities and international commitments. Next slide, please. So this slide illustrates the institutional position of the office. Office functions as the national coordination body, ensuring cooperation between ministries, health and social services, law enforcement authorities, local authorities, and civil society. Our role is not only operational service delivery, but coordination, monitoring, and policy leadership. Next slide, please. So drug demand reduction in Serbia is structured around the comprehensive continuum of care model. This approach connects prevention, treatment, recovery, and reintegration into one coordinated system of support. Prevention is implemented through evidence-based and national community programs at school and community level. Treatment ensures coordinated health and social welfare services. Recovery includes structured rehabilitation programs, particularly therapeutic communities and psychosocial support. And reintegration focuses on long-term rehabilitation, employment, and social inclusion. The objective is to ensure continuity of care rather than isolated interventions. Next slide, please. So Serbia's drug demand reduction is grounded in the law on psychoactive substances and the national strategy. Following the final evaluation of the previous strategy, a draft of operational plan for 2026 to 2027 has been prepared and submitted to competent authority, ensuring policy continuity and further evidence-based improvements. So next slide, please. An important component of our national response is National Early Warning System on New Psychoactive Substances. Through the Ministry of Health Center for Drugs Monitoring, Serbia serves as a national contact point for EUDA. This system enables a rapid information exchange, risk assessment, and national coordinated response. Next slide, please. So to strengthen structured and coordinated pathways at local level, the office, in cooperation with the Association Izlazak, established multidisciplinary teams focused on recovery support. These teams bring together representatives of the local self-government, health and social services, education, and law enforcement and civil society. They participated in the evaluation of the national drug strategy. Also, as part of capacity building efforts, an online lecture was organized with the Professor David Patton from the University of Derby. So next slide, please. Therapeutic communities in Serbia represent a cornerstone of Serbia's long-term rehabilitation model. Active communities include Zemlja živih, Preobraženje, Duga, Reto ima nade, and Raskršće. More than 7,000 beneficiaries have been supported through structured residential programs lasting between 18 and 30 months. So in recent years, a significant increase in cocaine-related admissions has been observed, currently exceeding 35% of residents. Next slide, please. The model demonstrates measurable outcomes. Therapeutic communities reported that between 20 and 35 beneficiaries complete the program annually per community, with an estimated long-term rehabilitation success rate exceeding 70%. Next slide, please. Despite positive results, several challenges remain: increasing cocaine use, capacity limitation, financial sustainability, and barriers to long-term reintegration require coordinated and sustainable policy responses. Next slide, please. So our strategic priorities include expanding residential capacities, strengthening interinstitutional coordination, ensuring sustainable funding models, and reinforcing reintegration-focused follow-up programs. The office will actively work to facilitate access to national and international funding models. Next slide, please. The Republic of Serbia remains firmly committed to advancing balanced, comprehensive, and evidence-based drug demand reduction policies. Thank you.
Thank you so much, Nina, for a wonderful presentation and also giving us the hope of recovery. And this is really important because you said 70% of success rate. And this is really fantastic because when we speak to people around treatment and recovery success, it's like 2 or 3%. So this is a completely kind of changed perspective on how treatment and support from the government and also your multidisciplinary teams can enhance and actually the outcomes for people in need. Thank you so much. Okay, our next speaker is Dr. Mark von Omeren, hopefully. He's head of the Mental Health and Substance Use Unit in WHO headquarters in Geneva. He has played a key role in the initiation and development of a number of major interagency and WHO initiatives, including MHGAP program covering mental, neurobiological, and substance use disorder. Dr. Mark, you have the floor, and hopefully I have pronounced your surname.
I think you did a wonderful job. Thank you so much thanks for the government of Serbia for the invitation to speak. The next slide, please. WHO is the lead UN agency for public health, and this substance use can lead to many health problems. So we have a lot of work in this area. Next slide, please. In this classic publication, we outlined the 5 dimensions of public health as relevant to substance use. So, and here they're on the slide. And in this presentation, brief presentation, I will focus very much on prevention, treatment and care, and recovery, and less on access to controlled medicines and on monitoring, which is of course also very important. Next slide, please. So as already mentioned by Sanita, this is a very well-known document. You'll be familiar with the international standards on drug use prevention and the international standards for the treatment of drug use disorders that we developed, WHO and UNODC together, and has been acknowledged by member states in multiple resolutions and fora. They summarize the evidence and together develop a full continuum of care from early prevention to recovery management. And this builds on available WHO normative recommendations, very in-depth survey of the evidence. We are very pleased that these documents are widely translated and used, and still are mindful that these evidence summaries need to be updated all the time because our knowledge is developing. And next slide, please. What is probably not so well known, that WHO has a global status report, which used to be just called the Global Status Report on Alcohol. But in this report, it also covers health and treatment of substance use disorders. And what we did is we obtained data from member states to give an update on the service capacity across the continuum of care in different countries and regions. A questionnaire with 300 indicators goes to member states to understand the service capacity in different countries and regions across domains such as service delivery, health workforce capacity, health information system, financing, and governments. It gives a good idea what elements are actually available within a system. And the worldwide capacity of varies widely. That can be seen in those graphs. Of course, you cannot see the details, but you can see that the richer countries have more capacity, as is obvious, than ones with less resources. But it varies significantly, ranging from 1% to 80% in terms of having all the elements in a system. So no country has it all. This information is available for each country in the Global Status Report, which may interest you. And some findings are peer support services are not available in around 50% of the countries. Screening and brief intervention is not available, but 40% of the countries. And if it's available, doesn't mean it's available everywhere. But if it's not available, it's not available anywhere. So it really shows how much there's still to be done. Next slide, please. We have a number of guidances on prevention of substance use. There's the screening and brief interventions to assist. There's treatment of mental disorders, which can help prevent the later onset of substance use disorders. But there's also more on the more distal determinants, like work in school, keeping children in school, preventing dropout, and having appropriate policies on what to do when in school there is substance use, non-punitive solutions. Next slide, please. In terms of clinically, WHO has a number of clinical guidelines on the management of substance use disorders, and we're very pleased that we're updating right now the guideline on psychosocially assisted pharmacological treatment of opioid use disorders, and the guidelines on community management of opioid overdose. We expect these to come out later this year, and it will be very important for member states to consider these to update their care. We also have a guideline on the management of substance use and substance use disorders in pregnancy, which remains relevant and will update in future. Finally, next slide, please. Not finally, but next slide. In terms of recovery is a big word, and we have studied what are the recovery-oriented services that have the best evidence from randomized controlled trials. And we found that that there's some evidence, enough for us to implement, for people to implement, For digital recovery support, user involvement care models, whether spiritual, religious, role of self-care, mindfulness-based therapy is very popular these days, physical exercise, occupational therapy, different forms of employment support, for example, individual placement and support, peer recovery support services, case management, assertive community treatment, and long-term approaches for housing and family support. So there's quite a bit of options to strengthen recovery, and that's what needs to be implemented. Of course, we acknowledge that much of the evidence is from high-income countries, and much more research needs to be done in low-income countries. Next slide, please. In headquarters, as in many UN agencies, we mainly concentrate on the development of technical and normative guidance, as we just presented. This work needs to be implemented in the regional country level. So we cheerlead the interagency work. Together we are stronger. UN needs to work together. So we are very pleased that the UNODC WHO program on drug dependence, treatment and care. And with UNICEF, we have a joint program on mental health and psychosocial well-being and development for children and adolescents. And those are ways of being significant in countries. That's my next slide. This is my typical closing slide. Thank you very much. We will be happy to support countries together with UNODC as necessary. Thank you.
Thank you. Thank you so much, Mark, and thank you for sharing all the resources and doing so much in creating guidelines and providing all of this as a very kind of accessible resource. So that's really amazing. And we have finished our kind of in-person part of this event, so we still have one more speaker who will give his presentation online. But I just wanted to also thank our colleague Cressida De Witte, who is the project coordinator at WFAD, who is one of the co-organizers of this event, for helping us do this in a hybrid way. So she will now play the video that was sent by Dr. Ed Day. He will probably introduce himself in the video. So I'm gonna keep the time for at least one question or two questions after this. So yes, we can start.
Many thanks for asking me to talk about the central importance of the continuum of care in offering services for people with drug and alcohol problems. My name's Ed Day. I'm an addiction psychiatrist working in treatment services in the UK and also a clinical academic at the University of Birmingham. Whenever I talk about this topic, I always show this slide first. I like to consider people's engagement with substances as occurring across a spectrum, as it's shown in the top of this slide. So on the left-hand end of the slide, there are people that either don't use for religious, cultural or other reasons, or use substances in a way that merely enhances their life and causes them no problems. On the right-hand side are people with significant substance use disorders or dependence, and this would be the group, maybe 5% of the population that are actively involved in treatment services. In between, we've of course got every different level of engagement with substances, and the group in the middle, maybe 30% of the population, are starting to develop some problems, either biological, psychological or social, but without necessarily awareness of this. Now, if you have that range of engagement with substances, you need a range of ways of managing this. And along the bottom of the slide, we can see a spectrum from public health, educational messaging to try to enhance health generally, through to treatment services and recovery support following on from treatment. This slide is very important. It summarises the sum total of our knowledge about addiction treatment services worldwide. We're aware that on average, when someone becomes aware that they've developed a problem, it takes them 4 to 5 years before they even seek help from others. They'll normally try and deal with the problem themselves. Once they've sought help, whether that's from a specialist treatment service, a primary care physician or a self-help group, on average it takes 8 years before they get into a state of sustained remission from the problem. But here's the key point. It then takes on average another 4 to 5 years before their risk of relapse drops to the level of the general population, and they can say that they they generally have the issue under full control. Now, because we are aware that it takes that length of time, we need to think about interventions that can occur after remission and very often after an episode of treatment is finished. And this is where the concept of recovery comes in. I understand recovery to mean three key elements. The first is obviously remission or control of the problematic substance use. For many people that would be abstinence, but not always. But you can have control over the substance use without recovery, because recovery also involves having good physical health, good mental health, and a satisfying life, participation in the rights, roles and responsibilities of society, jobs, friends, housing. There's lots of ways of defining it. But together, I think those two elements, health and quality of life, we can think of as the concept of recovery capital. There's no one path to recovery. This is a process from serious addiction. This is a process that takes a considerable length of time. It requires aspiration and hope and usually connection to other people. And the point is that treatment services very rarely provide all of this. Treatment services are extremely good at getting people into remission, but we know relapse is common. Making it out to 5 years is difficult. So the job of a full continuum of care is to consider how to build recovery capital, and how that particularly involves adding in strengths-based interventions that are looking at how we can build someone's strengths up so that they can function fully in society. And the two ways we've done this in the UK are to firstly define what we call recovery support services, and secondly to build up lived experience recovery organisations. Now, recovery support services are defined in a document, in a monograph we've written, which distills out the mostly North American evidence for 6 different areas of recovery support, and you can see them listed in this slide. So they're led by peer-based interventions, but also include centres where people can gather to receive such interventions and get involved in social activities, absence-based housing, recovery in university campuses and other educational settings, and recovery check-in and employment support. But we also feel that although anyone can deliver those interventions, they're often best when they're delivered by people with lived experience. And we've developed this concept of a lived experience recovery organisation. So that's a grouping that's come together from a community, usually of people in recovery, who have put together an organisation to facilitate helping people to build that recovery capital. And you can see here on a number of the reasons why a lived experience organisation might have particular strengths in this area, ranging from strengths in an asset-based approach, but also through to being more effective at challenging stigma and involving other community members such as family and friends. And the whole sum of the recovery support services combined with the lived experience recovery organisations really is aimed at getting visible recovery out there, to get activities that are happening in local communities around treatment services where people can see that recovery is both possible, that is a reality, is a realistic expectation for them, and is also a gateway and a way of helping them to achieve this in reality. And here are a range of different activities that are delivered either in recovery support services or by LEROs in communities, which finish off this continuum of care to enable people to move out of addiction and into long-term stable recovery. And we can, as a final thought, we can put this together in one diagram. So this is my idea of a continuum of care. Apologies that it's presented as a nice linear straight line diagram. I'm well aware that no one's recovery follows that pathway. But if you think of on the left hand side as being in active addiction and on the right hand side as being in recovery, we can think of the need for a full range of harm reduction interventions to engage people and to keep them well and healthy and alive whilst they consider the options available within treatment to help them change behaviours and get them under control. And then finally, we have a range of recovery support services that can help sustain those gains made in treatment and help people flourish and move on with their lives. And you can see that range of recovery support services might be beneficial at different points of this treatment spectrum. Thank you very much.
Okay, we are running so much over, but I don't want to finish this event without having this floor open for any comments, any questions, first in person and then online.
Hello, and thank you to everybody. This was really wonderful to hear all of the different frameworks and the different resources you offered to think about this continuum of care a little bit more in depth. My question is, for those of us who are probably working in kind of governance contexts that might not be as that might not digest this information well. I'm kind of curious on your insights as to if you faced any tensions introducing this idea on more of kind of like a policy level in general, and how you would advise those who are on the advocacy level to push this idea forward in a more helpful and pragmatic way. Thank you.
Yeah, I think it's a really good question. I think it's a real, it's question based on reality. So in my talk, I was talking about parallel tracks. Some people would describe the different systems as oil and water that they will never mix. And we've got to accept the reality that, the positivistic approach that creates the knowledge base, the evidence base, that then informs the design of the models of the services is based upon a colonial logics, and it refutes indigenous forms of knowledge. So therefore, we're always going to come up when we're advancing for lived experience approaches that Dot and others that are advocating for, that we see impact for. It's always a battle between the two tracks. And that's why I think in my talk, I was advocating for a neuroplastic approach. So we're not saying let's choose one over the other, but how can we create a third way so that both tracks can still coexist, but we're not allowing the people in recovery to suffer. So get neuroplastic would be my suggestion.
Thank you so much. We have to leave the room, but feel free to stay in front of this room and ask our speakers if you have more questions. Thank you so much for attending the event. And thank you, Serbian government, for organizing.